I was just checking the recording. I seems that due to this hustle, I will have to repeat the first 1 hour of the session again later to record it for the people who missed it. So because of this hustle, but it's not a big deal. Actually, I have many recordings for it before, but I will still record it for the people who missed it today. I need to make sure that everyone. Can you hear now, Dr. Masih? Dr. Masih, can you hear now? Okay, fine. So I will sort it out for the people, for other people, like because I promised that this session will be recorded. It's not a big deal. I will do it. So now the psychosocial. It's not only giving you the chance to like it's not only giving you the chance only to ask and get marks for data gathering. No, it's giving you the chance to, like, how can I say, to rebuild your mind, to regain your mind and your track. Why? Because you have been asking questions for at least 2 or 3 minutes and you are now consumed. You are thinking too much. You are more or less sounding scripted at some point. So when you are asking the patient how has this affected your life, especially in the long-standing complaint, do not ask the patient how has this affected your life if he is presented with you with acute cough. For example, if the patient is dying and is having shortness of breath, and you're asking him how has this affected your life, he will tell you, doctor, please uh, don't be silly. Enough, doctor, enough of silliness. So this guy is losing his life and you're asking him how has this affected your life? Don't do this. Just ask about the prolonged tiredness, prolonged shortness of breath, maybe what else? Prolonged lack of sleep, prolonged insomnia. These people usually love these complaints too much. Even prolonged diarrhea. You can ask the patient this question. Okay, okay. Um, so one important thing here to not forget is that this question is magical. In some statements, you will see by yourself how has this question affected your management, not only your management, but also your data gathering. Promise. I promise you. Okay? Okay. How to ask this question? Usually some people prefer asking it in the beginning after each complaint. This is not true or this is not right. For example, the patient gave me long-standing tiredness and he may give me later a long-standing sleeplessness. So why don't I ask this question after finishing my data gathering? For example, I take full history and I ask about the lifestyle right now. After asking about the lifestyle, I will ask the patient and tell me how has this affected your life. So it usually comes in the end of data gathering because if you ask after each and every single complaint, you will be wasting much time. It's good, but you'll be wasting much time because what if he is giving you too many long-standing complaints? So please keep this question in the end. Okay? If you are very confused, you can ask it before moving to the maftosa or moving to the past medical history. If you are really confused or if you do not want to miss it. For example, Dr. Yemi, for example, he told me that he is having this shortness of breath and this tiredness since maybe 2 months. And I asked about the associating symptoms like maybe heart racing, like losing weight, like loss of appetite, like maybe lightheadedness. Okay. And after that, before moving to the Maftusa or the past medical history, I asked him, and how has this affected your life? After asking this question, I can move right now to the past medical history by asking him, has this ever happened to you before? How was your health recently apart from what you told me? Do you have any medical condition like this? Okay. Okay. So I prefer that you use it in the end of data gathering. But if you still insist on using it efficiently, you can use it just before moving to the past medical history. Okay? Before moving to the past medical history or before moving to the Maftusa. Actually, PMH or past medical history in some academies and some other academies may call it Maftusa. Okay? Okay. So here comes two exceptions because life is not easy. There are still two exceptions. What? The exceptions here are the skin lesions and the breast lumps. More or less, they are the same, by the way. But there's one trick. The skin lesion, you will ask the patient, where is the lesion? Number one. When did it start? Do you have any idea how did it start? Okay, do not be awkward if you ask the patient, has it been continuous or comes and goes? If it is a rash, I can understand. Rash usually comes and goes. But if it is a lump or skin lesion or a lump, don't ask the patient, has it been continuous or comes and goes? Why? This is ridiculous, seriously. You think that you can be having a skin lump which comes in the morning and disappears in the evening? This is magic. This is only in the movies. So do not ask this question in the skin lesions if there's a lump only. So you will ask him, instead of asking has it been continuous or comes and goes, you will ask the patient, has it changed? He will tell you, changed how, doctor? For example, what is the color of the lump? He will tell you, doctor, it's black. Has it changed in color? No. What about what is the size of the lump? It is, doctor, like maybe 1 by 1 centimeter. Or he can show you like a coin. Tell him, has it changed inside as well? No. Does it bleed? No. Does it ulcerate? No. Is there any discharge from it? No. So those are the questions. Size, shape, color, and any change in them. Then bleeding, ulceration, and discharge. Why? The last 6 questions are very exclusive and specific for the malignancy. Okay? Okay. So this is number 1. Number 2. For the breast lump, you will ask the same questions. Site, size, any change in site or size or shape? No. What about any bleeding or ulceration or discharge? But in the breast stations, you have also to add the nipple, because most of the breast lumps, especially if malignant, they can also be associated with nipple changes. So here in the breast, you will add the nipple. Any changes in the nipple, any retraction, any bleeding, any discharge from the nipple. Okay, the breast lumps as well, you will add the armpits. What about the armpits? Have you noticed any lumps in your armpits? No. These things will be given to you today. Don't worry about them, or ultimately tomorrow morning, and you will read them in half an hour. Okay? But I'm sure that most of you know about them, but it's just you are not aware about how to ask about them. So any change in the armpits, and the nipple. So the breast lump, we will add the armpits and the nipple. The skin lesions, it's similar to the breast lump. Okay. And after elaborating the breast lump or the skin lump, you will ask this question. Any other lump elsewhere in the body? Do not forget to ask this question, because it can happen or it can be useful in some stations like the HIV station, the new ones. Okay? Okay. So, one important thing to also not forget is that maybe if you are having any complaints, like if you are having any challenging complaint, um, any challenging complaint, for example, if you do not know about the complaint, or if you are confused about it, you will elaborate it the same way I'm doing to you. Any complaint that you do not know in PLAB 2, you will elaborate it like that. Odipara, okay, it's good to say Odipara, but it's better to know how to ask it Odipara, because I know that all of you know Odipara, but when it comes to the real setting or the real questions, all of you are confused about it. To ask about it, number 1, when did it start? Number 2, how did it start? Number 3, has it been continuous or comes and goes? Number 4, has it changed? Number 5, anything makes it better? Number 6, anything makes it worse? And in some complaints, you can ask about a specific time of the day. Okay? Okay. This is for any complaint in PLAB 2, because the complaints can change at any time. New complaints can come and new stations can come at any time. Okay? Okay. So, now let's move to one interesting thing, which I personally like, and it's challenging for some, but for me, it is the most easy part of the history taking, the psychiatric history. For psychiatric history, I know some people who just fail the psychiatric stations because they do not know how to take psychiatric history. When I tell them psychiatric history, you know what they tell me? They tell me, oh, yes, the MC fam or the MC famish. Okay, it's good that you know about that. But you know how to ask about it? No, doctor. Okay, so what we suggest, number one, for any patient in PLAB 2, they are having presenting complaint or presenting issue. You will address the presenting issue. Okay, for example, for the suicide, because this is the most important thing to elaborate in details. For suicide or drug abuse or any psychiatric station, we usually will have separate session for psychiatry anyway, but let me give you a quick hints about how to take psychiatric history. For the suicide, you know what to do. When did it happen? This is number one. Number two, mind the setting, please. If your setting is A&E, this means that you still have to elaborate it medically. And how to elaborate medically? By asking some medical questions like, when was that? And how did you take these tablets? Whether in one go or at separate times? What have you done after that? Have you tried to throw them up? Did you take anything along them? Any alcohol or recreational drugs? Okay. How have you felt after that? Any tummy pain? No, doctor. So these medical questions are important if you are in A&E, but if you are in psychiatry, the patient will tell you, doctor, I took maybe like 20 tablets of oral contraceptive pills. Okay. The next question will be, why did you take them? Because in psychiatry, we are elaborating the reason. But in A&E, we need to treat. In A&E, we need to treat. We do not need to explore the reason. Your life is more important than your psychology in A&E. But in psychiatry, this means that the patient is stabilized already, and he is here to take some psychology or take some psychiatric history from him or her. So, in terms of psychiatry, and by the way, we'll speak about these stations later in details, but in terms of psychiatry, you have to elaborate the presenting complaint at first. Can be suicide, can be drug abuse or drug addiction, can be delusions, can be depression, can be anything. Okay, okay. In the psychiatry day, I will provide you with some short notes about how to elaborate each complaint from them, because it is only the whole station is about how to elaborate the presenting complaint. Management and social history are very easy. It's just I need to teach you how to elaborate the presenting complaint. Okay, so you will elaborate the presenting complaint in psychiatry. After that, if the complaint is about drug addiction or alcohol or substance addiction, you will ask these questions. CAGE, DWT. CAGE, DWT. What are they? For the CAGE, it was, have you ever thought of cutting down? This is a C. And for the A, it is, do you feel annoyed by other people when they speak about this or when they tell you about this? For the G, do you feel guilty about it? And the E, do you take it as an eye opener? Eye opener means first thing in the morning. So CAGE questions, we told them. Then DWT. What is the DWT? D stands for dependence. I will ask the patient, are you able to perform your daily tasks without taking them? And for the W, it is withdrawal symptoms. Have you ever experienced any unusual symptoms when you try to stop them? And for the T, it is tolerance. Do you think or do you feel that you need to increase the dose to reach the same effect? Okay, those are the CAGE DWT. Those are exclusive for the substance abuse. Either the substance is alcohol, either it is heroin, either it's anything. CAGE DWT for any abuse. Okay, number two, very important. It is for the suicide. The suicide, we elaborated the suicide attempt, but after elaborating the suicide attempt, we ask the RRP question. So for the substance abuse, CAGE DWT. But for the Suicide, we ask the RRP. What are the RRP questions? Regretfulness, recurrence, and planning. I will ask the patient, do you regret what you do? Do you think that this is the first R, regretfulness. Recurrence, do you feel that you are going to repeat it again? Have you ever tried suiciding or harming yourself before? Okay. The P stands for planning. Have you ever planned doing it? Did you leave any note? He or she will say, no, usually. Because usually it is acute psychiatry. You're having most of the patient, it is the first time suicide. Because if it is repeated suicide, usually you will not be the one who is talking to them. Usually there will be senior consultant talking to them. Okay? Because this is recurrent and this means that the patient is high risk, already high risk, and they need to be admitted even under the Mental Health Act right now. Okay? Okay. So, KHDWT for substance abuse, RRP for the suicide, right? Okay. There is always some few exceptions. What are the few exceptions here? The few exceptions here will be like, for example, the delusion case. The delusion case, there is no pattern for it. But let me assure you that this case is the most enjoying and the most nice psychiatric station, especially if you are not like, how can I say, if you are just like nice to the patient. Nice how? He's like a child. He's like a child, seriously. You do not need to focus on your data gathering too much. You need to reassure him. I will demonstrate it with you in a few days, inshallah. This station, because in this station, though it's high yield fail, I don't know why many people fail this station, and they even fail it like epic fail, like maybe they get 3 or 4 in it. Some other people I know, they got 11 in it without being efficient in history taking. The only explanation is that in psychiatric history, you have to be slow. You are dealing with a patient who is psychologically or cognitively impaired or having psychological problem, or a patient who needs to talk and needs someone to listen to them, or the patient who needs reassurance after coming after a suicide attempt, or a patient who needs encouragement to stop the drug they are using or the substance they are using, or a patient who needs someone to boost their mood because they are depressed, or a patient who is losing weight and needs someone to convince them that losing this weight is harmful for their lives, the anorexia nervosa. So usually the psychiatry stations are not about the history. No, it's about how you will deal and address the patient. The psychiatry patient needs special treatment. Okay? Okay. Two people usually need special treatment. The old group and psychiatry patients. The old group, believe me, if you get any old guy or any old woman, any old lady, it's PLAB 2, your chance of getting high interpersonal skills are higher. Because these people love talking too much and they need the people who listen to them. Your only mission is to listen, and we will try that. Okay, let's resume psychiatric history. Psychiatric history, the core of psychiatric history after the elaborating the presenting complaint and after taking some special questions like the KGWT or RRP. After doing that, here comes the most important part, which we call part of risk assessment, which is the social history. Social history, which is a FAMISH. Number one, F. The F stands for family, friends, finances, and forensic. For the family, I'm going to ask the patient, whom do you live with? Okay, how is your relationship with the people you are living with? So I will ask whom does he live with and how is his relationship with them? Okay, okay. This is number one. Number two, for the friends. Do you have any friends? How is your relationship with your friends? Do you meet frequently? Okay, this is number two. Number three, the finances. Are you financially stable? May I know what you do for a living? This is a finance. Okay, for the forensic. One question. Have you ever had any problem with the law? Do not ask have you had any problem with the police, because in one station, which is delusion, the moment you will say the word police, literally the patient will jump from his place. So do not ask this question. You'd only say, have you ever had any problem with the law? Fair enough. This is for the F. Number 2, the A, which is the alcohol. Do you drink alcohol? When the alcohol, when you always ask about alcohol, don't forget to mention the recreational drugs. So by any chance you use any recreational drugs? Okay. Now comes the M. We agreed that it is famish. Famish, we finish the F, the 4F. We finish the A, which is alcohol and recreational drugs, and then the M. The M stands for the mood. The mood is very important in psychiatric history. By the way, some people failed psychiatric station for one reason, that they did not ask about the mood. Though they asked every question, but they forgot to ask about the mood. Why? Someone is coming to you as a psychiatrist. Do you think that you can miss his mood or her mood? It's the core of any psychiatry. So do not miss the word mood. How is your mood recently? Can you score your mood to me on a scale from 1 to 10, 1 being the lowest and 10 being the good or the highest mood you have ever had? So this is the mood. Always remember that the mood is associated with a suicide. Why? Because the lower your mood is, the higher your chance to commit a suicide. So after asking about the mood, always ask about the suicide. Have you ever thought of harming yourself? Okay? Okay. What else? Now you are done with that. After the mood and suicide, now move to the mental and medical health. For example, did you have any mental health problem? Any family member had any mental health problem? This is the mental. Medical health. Do you have any chronic medical condition? Do you take any medications? Any family member with any medical condition? Why I'm asking this? Because most of psychological problems, they run in families. Depression runs in families. Delusions run in families. Schizophrenia runs in families. Whatever runs in families. Medical history, as a safe doctor, you have to ask 2 questions from medical history. So I'm going to ask him, do you have any medical condition? Do you take any medications? So to sum it up again, famish. They are family, 4F, which we say. Then the A, alcohol and recreational drugs. M is the mood, and the mood is always associated with the suicide. Okay, we say it. The I stands for the insight. You do not need to ask about it in psychiatry usually. And only in one station, which we will speak about later. Okay, which is the anorexia nervosa. So the S stands for suicide. The H stands for hallucinations. You do not need to ask about them except only in one station, which is the delusion. And sometimes in substance abuse like the heroin or the alcohol. Okay, then you will ask the mental and medical health. Very important. Okay, this is psychiatric history. Psychiatric history will be even easier when we explain psychiatric stations in one day. And guess what? It will be explained only in 1 hour and a half. Because I will make you fully aware about it. I promise that. Psychiatric stations are barely 7 stations. The only challenging of them is the mini mental state examination. It is the only odd case. And for the mini mental state, I will print a paper for you about it and how to ask about it in details. You do not even need to memorize it. You only need to practice it in the right way. So usually for anyone who's coming to practice with me after the 15 days course, one of the stations which will be included in the mini mental state examination. Okay, this station you can either score 12 in it, or you can score 11 or 12 in it, or you can score 3. It depends on one thing, which you will say next, inshallah. Okay, now we are done with the psychiatric history. Okay, let's speak about some challenging things. Number 1 is that sexual history. I noticed that some people, not some, actually most of the people, they do not know how to take sexual history. How come you are telling the patient, I'm going to ask you a few personal questions, so do not feel embarrassed. And after starting to ask, you yourself look embarrassed. Why? It's very simple. You know what to do? Here in psychiatric stations, you are going to tell the patient, I am going to ask you a few questions. Okay? Don't feel embarrassed or don't be shy, because as medical professionals, he asks them to all our patients. Or simply you can tell him, I'm going to ask you a few personal questions. Okay, for sexual history, we need to ask, first of all, are you sexually active? Okay, the sexual history needs to be in a chronological manner. For example, do not go and tell the patient, do you practice safe sex? Doctor, I'm not even sexually active. So see, you have to be chronological, you have to be organized. Well, so I'm going to start with, are you sexually active? He says, yes, I'm happily married, for example, since 5 years. Well, that's great. He told you that he is happily married since 5 years. Do not ask him, is it a stable relationship? Because he told you that I'm happily married. This means that it's already a stable relationship. You do not divorce and marry again. No, it's a stable relationship. So the patient told you, we are happily married since 5 years. Okay, now you can ask him, do you practice safe sex? He will tell you, yes, doctor, most of the times. See, this word most of the times mean that he had episode of unprotected sex. Do you know when was the last time you had unprotected sex? He will tell you, for example, it was 2 weeks ago, doctor. Any other episode? No. Okay, after this, I'm sorry to ask you, but by any chance any other partner? He will look awkward. He will look stressed and concerned. He may think that you are judging him. Why are you asking me this question, doctor? As medical professionals, we usually ask these questions to all our patients. We do not judge them nor catch them out. So your mission is to show him that these questions are very familiar to be asked by you and your colleagues. So please do not feel stressed. He will tell you, yes, doctor. I traveled to Germany 2 weeks ago or 3 weeks ago, and I had one night stand in it. Was this unprotected sex? Oh, yes, doctor. We had unprotected sex. Okay. And any other episode or any other time? No, doctor, not really. So number one, are you sexually active? Number two, number two, number two, do you have a stable partner or are you in a stable relationship? Number three, do you practice safe sex? Number four, did you practice or when was the last time you practiced unsafe sex? Number five, by any chance, any other partner? Number six, was it unprotected sex? That's it. This is sexual history. In the notes that I'm going to provide to you, I will not tell you what to ask precisely. I will write you short notes. For example, number one, sexual activity. Number two, stable relation. Your mission is to always paraphrase it. For example, I'm not going to remember, are you sexually active? Do you have a stable partner? No, you can alter it your other way. You can add some phrases like by each, tell me, are you sexually active? Or tell me about your sexual activity. Like this. Okay, this is sexual history. Then comes some problems. What are the problems? Usually there are some diseases in PLAB2 that you have to elaborate in details, like hypertension, diabetes, COPD. I'm going to tell you, Dr. Yemi, every single detail right now. I do not miss anything, don't worry. I'm going to tell you how to signpost, how to say everything before each special pattern. I will say this in the end of the history taking right now. Okay, there are some diseases which you have to know how to elaborate them in details, like hypertension, diabetes mellitus, COPD. Those are very important, and as well, of course, the cholesterol, and if she had or he had any surgery in the past. For the hypertension, you never miss how to elaborate it. Simply, how is it managed? He will tell you, doctor, I'm taking Ramipril. Are you taking it regularly as prescribed? Any recent change in the dose? Any extra or missing dose? Those are the three questions for any drug. Do you take regularly? Any recent change in the dose? Any missed or extra dose? Okay. You asked about the drug. Can you say now if your blood pressure is controlled or not? Can you tell me if your blood pressure is controlled? What do you mean, doctor? For example, don't you experience any symptoms? Like what? Like any headache? No. Any blurry vision? No. Any heart racing? No. That's great. Do you have any complications of the high blood pressure, or did you experience any complications? Like what? Maybe a swelling in your legs? No. Any shortness of breath? No. So for elaboration of any disease, you will ask about how is it managed. Number two, compliance with the treatment. Number three, very important, to ask about the control of the disease by asking about symptoms. Number four, to ask about the complications. And in the end, do you follow up regularly? Do you follow up with your GP or you attend your annual review? Yes, doctor. Okay, this is for the hypertension or the diabetes. But you can add also two things. You can ask him in the middle, do you measure your blood pressure regularly or do you measure your blood sugar regularly? When was the last time you measured it? Okay, so again, number one, how is it managed? Number two, the compliance with the treatment, like do you use it or do you take it regularly as prescribed? In recent dose or any recent change in the dose? Any missing or extra dose? Okay, okay. Then you will ask him about the control. Is it well controlled? For example, do you experience any symptoms? Like for the diabetes, you will speak about any, for example, do you go to the loo more often? You feel thirsty these days? Those are symptoms of diabetes. So you pick up two symptoms from each disease and ask them in the control. Okay, ask them, do you experience any complications? For the hypertension, the complication could be heart failure or heart problem. For the diabetes mellitus, the complication could be, the complication here could be actually any food problem or eye problem. Okay, after that, do you measure regularly? When was the last time you measured? And then speak about the follow-up. Like, you usually follow up regularly? Do you attend your annual review or your GP is like this? Okay, so now let's speak about the COPD. COPD is a little bit, no, it's actually similar to what we mentioned. But the problem is that in the COPD, do not forget to ask, okay, for example, I'm going to ask him, when was it diagnosed? How is it managed? Do you take the treatments regularly? There's only one problem, is that one of the treatment is the blue inhaler. So I have to ask him here how often you use the blue inhaler these days, because this is part of the control. If he is using the blue inhaler more often these days, this means that his COPD is not well controlled. So it's similar to any other complaint, but the blue inhaler, I have to ask about how often you use it. Okay, this is number one. And number two, please, in the complications, ask him about the cancer symptoms, like any weight loss, any tiredness or shortness of breath. Why? Because one of the complications of the COPD, especially in the old age patients, it is lung cancer. Okay? Okay, guys. So for any disease, you will ask, how is it managed? And compliance with the treatment, number two. Number three, do you experience any symptoms? Number three, do you experience any complications or not? And number five, you have to ask about the follow-up. You usually check it up or follow up with your GP. This is for any disease, any long-standing disease. Okay? What about if the patient tells you, yes, doctor, I was having maybe cough and shortness of breath also 2 months ago, and I went to the A&E. You will ask him this question, and what was done? What did they tell you? So how was it managed, and what did they tell you? This is for any episode which happened once. For example, he told you that I was having abdominal pain 2 months ago, and I went to the A&E. Simply, you will ask him, what were you given or what was done, and what did they tell you about it? Okay, so now we're almost done with our data gathering. But there's also one thing. In the pregnancy station, or if the patient is pregnant, you will ask some questions for the pregnancy. Number one, can you confirm the age of your pregnancy? Number two, you will ask the patient, how has your pregnancy been so far? Any problems with your pregnancy? Like any vomiting, any severe tummy pain? No. Okay? This is the first time pregnancy, or have you been pregnant before? Okay? So the three questions for the pregnancy are: number one, confirm the age of pregnancy. Number two, how is your pregnancy going, or how has your pregnancy been so far? Like, for example, any symptoms or any problems with your pregnancy. This is number two. Number three, do not forget to ask about any previous pregnancy. When she tells you that I was pregnant before, you will ask her, when was that? How old are they? What was the method of delivery? Any complications happened? Those are the exclusive questions for any previous episode of pregnancy, and we will speak about them in details in the OBG questions or OBG stations. You finished the previous pregnancy, now move to the antenatal visits. Have you attended your antenatal checkups? Yes, doctor. And how did they go? For example, what was the reading of your blood pressure in them? That's it. Okay? Okay. Those are exclusive for 4 or 5 stations. We will speak about them in details when they come. They are very short. So for the pregnancy and the antenatal, there are a specific pattern which we will speak about in the day of the OBG. Okay? Okay. One more thing. Now you are done with your history taking. As we all know that your history taking is 3 patterns. Number 1, presenting complaint. Number 2, associating symptoms. Number 3, sorry, 4 patterns. Number 1, presenting complaint. Number 2, associating symptoms. Number 3, DDs or differentials. Number 4, past medical history or maftosa. Number 5, lifestyle. And there is some add-ons in some stations, which we'll speak about. Okay, now I ask the patient the presenting complaint. After the presenting complaint, we have to ask about the associating symptoms. Like, for example, the patient is presented to me by cough and shortness of breath. I will pick up 3 or 4 associating symptoms, like, for example, any fever, any chest pain, any heart racing, any nausea, vomiting. So number 1, presenting complaint. Number 2, associating symptoms. Number 3, differentials. When you are studying any station in PLAB 2, you have to make your own mark, or you have to make your own form. I am going to write number 1, the presenting complaint is 1, 2. Number 2, I'm going to pick up 2 or 3 associating symptoms, and I'm going to fix them in my mind, in the back of my mind, so that I will ask about them in any station which comes to me, no matter if I know the station or not. But I will ask them in any station which can be related to this complaint. For example, in the cough station, I will ask all these symptoms. In the shortness of breath station, I will ask all these symptoms, like this. So the associating symptoms, they are fixed. You will fix them when you are studying. Number 3, the differentials. Before entering the cubicle, you will have to make sure that you're having 3 differentials in your mind for each complaint. For example, if the patient tells you that I'm tired, you will pick up the most 3 important complaints. For example, tiredness could be hypothyroidism, could be anemia, which can be due to cancer, could be diabetes. So anemia, hypothyroidism, and diabetes. Those are the most 3 diseases. So pick up 2 or 3 diseases in your mind. So now you finish the most important thing in your history: presenting complaint, associating symptoms, and then the differential diagnosis. What I used to do is that after finishing the presenting complaint, for the patient, for example, the patient told me that she is having cough. After elaborating the cough, most of the people, they go, and do you have any fever, any shortness of breath? No. After elaborating each complaint, ask the patient, do you have anything else? Why? This question is useful at least in 20 stations in PLAB 2. Otherwise, you will keep asking 10 questions before reaching an answer from the patient. So always ask, do you have anything else? When the patient says no, now you can ask whatever you wish. You can move to the associating symptoms and you can move to the differential diagnosis. It's very important. Okay, guys? Okay. Can you wait for a minute, please, guys? Wait for a minute. So, excuse me, guys. So, after finishing each complaint, ask this question. Do you have anything else? She says or he says yes. Okay, elaborate. Then if she says or he says no, now you can ask whatever you wish. Associating symptoms and 2 DDs or 3 DDs. Guys, there is a misconception. Some people think that I have to rule out all the DDs that could be related. No. Actually, from the presenting complaint and the associating symptoms, you already knew what is the reason or what is the diagnosis. Your only mission here is to rule out other DDs. So you can rule out 2 or ultimately 3 DDs. Do not rule out everything, just 2 or 3 DDs. And for each differential, you can ask 2 questions ultimately. 2 questions ultimately. And some differentials, actually, you can only ask 1 question for them. So please, guys, please, if anyone asks me too many questions, by the way, this is what harms the people in PLAB 2. People who know more are more likely to fail this exam because they ask all the questions that they know in their mind. This is not good. This is just 8 minutes. You have only to pick up the most important things. For example, for the SOL, I will ask the patient, do you have any morning headache? What about any blurry vision? See, I know that the SOL can be presented with weight loss and anemia symptoms and it's cancer, but 2 complaints are very enough. For the meningitis, I can ask only 1 question. Do you have any fever? This is very enough. For the GCA, I can ask 1 question. Do you have any jaw pain? For the pneumonia, I can ask 1 question. Do you have any fever? For the diabetes, I can ask 2 questions only. Do you feel thirsty? Do you go to the loo more often? 2 questions for each differential, and ultimately rule out 3 differentials. Please, do not go beyond this. I notice that the people preach while history taking. This is what makes you harm down or mark down in data gathering, because you ask too much. And always remember that it is just it can take you ultimately 5 minutes in your history taking. Do not spend more than 5 minutes and a half. And only in very few stations you can spend 6 minutes on history taking. Like the stations which show no diagnosis, like the prolonged diarrhea, like the chronic fatigue syndrome, like the bloody diarrhea, like maybe tiredness with gum bleed, like some stations, like maybe what else? Like the patient which is presented with maybe the hematuria patient and the hemoptysis patient. So in these cases, you have to dig more to find. And believe me, the longer this station, because it will take you longer in data gathering, their management will be usually in 1 minute. So it is balanced. The longer the history, the shorter the management, and the opposite. Okay? So please do not create the imbalance by yourself. Go for only 2 or 3 differentials, and after that, you are done. I assume you have taken your full mark for the history taking after doing this. How to take history? This is basically what Dr. Yemi was asking about. Now I know that the history is #1 presenting complaint, #2 associating symptoms, #3 very important thing is that you have to rule out the DDs, #4 move to the past medical history or the MATUSA, #5 the lifestyle questions, #6 some add-ons. Okay. Now I asked about the presenting complaint. Let's assume that the presenting complaint was chest pain. After elaborating the chest pain, I will ask the patient, do you have anything else? No. Okay. When someone is presented to us, for example, I'm talking to the patient right now, I'm going to tell him when someone is presented to us with chest pain, we need to ask a couple of more questions which can be related to it. This is what we call signpost. To show the patient that I'm asking him some questions which can be related to his own concern or his own complaint. I'm not a random person. I know very well what I'm asking you. So this is the use of signpost. I am going to ask you a few questions which can be related to chest pain. Then ask whatever you wish. After asking the associating symptoms, now move to the differential diagnosis. I noticed that most of you like excluding differential diagnosis while asking the associating symptoms. For example, some of you may consider that I asked the patient right now, okay, the patient is present with chest pain. So I asked him about any shortness of breath, about any fever, about any cough. This means that I ruled out pneumonia and maybe pulmonary embolism. Okay, that's good. But the better thing is to keep the DDs as separate entity. For example, in some stations, you will ask about each DD separately. Like the station of migraine. The patient presented with headache and she was having nausea and she was also explaining the headache that it was preceded by flashing lights and blurry vision. Not flashing lines, sorry, it was presented with zigzag lines. Okay, so now you'll ask about the associating symptoms, like maybe if she told you nausea, vomiting, you will tell her, for example, do you have any fever, any flu-like illness? No. My point of view is that you ask two questions about meningitis. For example, you keep in your mind that now I'm going to ask here about symptoms which can be related to meningitis. After these two questions of the meningitis, I'm going to ask two questions which can be related to the tension headache. I'm going then to ask two questions which can be related to the GCA. Why? This is a very easy way of history taking. Because you are dividing your history taking into chronological manner. Number one, presenting complaint. Number two, two or three associating symptoms. Number three, your differential diagnosis in a very organized manner. Each differential, pick up two questions for each differential and get rid of it. Instead of asking all the questions in random way. Many people will keep asking after the headache, they will keep asking any flashing light, any jaw pain. Why don't you simply ask about like this? Number one, I'm going to rule out glaucoma. So, for example, I'm going to ask here, did you see any flashing lights? By any chance, any pain in the back of your eyes? I am done with glaucoma. Now, move to the GCA. Did you notice any jaw pain during your headache? See, I'm done with the GCA. Now, I'm going to move to the meningitis. Did you notice any fever, any rash on your body, any shyness to the light? I prefer to ask about fever and shyness to the light, fever and photophobia for the meningitis. It's up to you. You can pick up any two symptoms. So now I finished each DD and I get rid of it forever. And instead of asking about every symptom which can be related without being organized and knowing what I'm asking about. I hope you got my point. If anyone, yeah.
Hello, can I ask one question?
Sure.
Just regarding the DD, when we ask about the differential diagnosis, should we put the emergency DD first or not?
This is a very good question. This
Yeah.
is very good. Dr. Rumi, actually, usually when you are ruling out DDs, usually we focus more on the emergency and on the cancer. Okay? The emergency and the cancer are the red flags because this what are can be one of them can kill the patient and the other one can can misguide you or you can misguide the patient. You can give him false reassurance in the management while he is really having possibility of cancer. So the most important things to ask about are the emergency and the cancer. But of course, in some stations you cannot use this formula because in some other stations it's not neither emergency nor cancer, and we know this. But you will see by yourself when you are moving forward that when you are ruling out DDs, you will be very specific in them. You will be like, you will know when to rule out cancer and when to rule out emergency. In some stations are not. Generally, the rule here is to pick up the most relevant things. That's why I gathered all the symptoms, for example, all the stations that can be related to one symptom together in the same day. Why? Because you will see yourself what are the most important differentials for each complaint. Okay, but you are right, the cancer and the emergency are usually our priority. And this is a good thing actually, because for the emergency you have to ask only one question. And for the cancer, you can ask 2 questions. This means that you ruled out 2 differentials and only 1 differential is remaining and you can go after it because you finished your job. Okay, now we are done with differentials. Move to the past medical history or the McTosin. How to do that? You will tell the patient, I'm going to ask you a few questions about your health, or let's have a quick review about your health. Tell him, has this ever happened to you before? How was your health recently? Do you have any medical condition? The patient usually says, no, I do not have any medical condition. Will you just keep silent? No. In most of the stations, even if the patient tells you, I do not have any medical condition, what you will do? You will ask at least about the hypertension and the diabetes. At least. In the respiratory station, you will ask about any lung problem. Okay? Uh, you have to ask at least about 1 medical condition, even if the patient says no. But still, you have to ask. Okay? Okay. So, one thing, um, in the recent health, some people may overlook this question. For example, after asking the patient, has it ever happened to you before? And apart from that, how was your health recently? Some people may overlook this question. No, this question is very important in some stations, like the vestibular neuritis, like the viral encephalitis, like what else? Like the Guillain-Barré syndrome, like the herpes zoster, like many other stations as well, like the asthma, because usually these things start after minor illness. So if the recent health is containing minor illness like flu in 2 weeks or 2 weeks back, this means that you already knew the reason for this illness and you knew the diagnosis as well. So please do not overlook this question. At least ask it. Ask it. How was your health recently apart from that? Okay, medical conditions, we spoke about it. Question number 4 in the past medical history is any medications. Do you take any medications, including over-the-counters or vitamin supplements? Not vitamin, just say supplements, including over-the-counters or supplements. Okay. Question number 5. Do you have any allergy to food or drugs? Question number 6. Have you ever been hospitalized or had surgery before? This question is not to be asked in all the stations, only in few stations, like the chest pain, like the older or the elder people with chest infection. Okay? Also, in surgery stations, you have to ask this question. So, not in all the stations you have to ask it. Why? Because it can be time wasting a little bit. Then, family history. Any family member diagnosed with any medical condition? This question is very important to ask because it's clue sometimes to some diagnosis. Now I'm done with the past medical history, right? Move now to the lifestyle. Before moving to the lifestyle, I'm going to ask you a few questions about your lifestyle. Or let's have a quick review about your lifestyle. Let's have a quick chat about your lifestyle. This is what we call signpost. So now before you move to the past medical history, you signpost that I'm going to have a quick review about your general health. And before moving to the lifestyle, you signposted by saying that let's have a quick review about your lifestyle or a quick chat about your lifestyle. Then, do you smoke? Do you drink alcohol? Are you physically active? Tell me about your diet. Okay? Okay. If the patient tells you, I'm smoking, you will ask, since when and how often or how much do you smoke? If about alcohol, can you tell me since when and how much? So for each thing of the lifestyle, since when and how much? Okay? Okay. Now we finish the fifth portion, which is a lifestyle. Now move to the important portion, which is the add-ons. The add-ons or the additives are in some stations. In the cup stations, do not forget the job and do not forget the travel history. job and travel history. Again, job and travel history. Very important, not to be missed. And what else? In any long-standing complaint, do not forget to ask about the job, because usually this complaint has affected their job. One more thing, in the skin problem, do not forget to ask about the travel history, and do not forget to ask about the job together with sun exposure. So travel, job, sun exposure in the skin. Travel, job, sun exposure. Okay, in the ear pain or the ear stations, usually, do not forget to ask about number one, swimming, number two, recent travel history, number three, about trauma, like injury to the ear. So travel, swimming, and trauma to the ear or injury to the ear. Okay? Okay. In the headache stations, do not forget to ask about the stress in life. Very important. In any female patient, in fact, do not forget to ask about the 4P. What are the 4P? Number one, period. Number two, pills. Number three, pregnancy. Number four, pap smear, but we do not ask about the pap smear. So consider them 3P. For the pills, have you ever used any contraceptive method? For the pregnancy, have you ever been pregnant before? And what was the outcome? For the period, very important at least to ask about the period. When was your last menstrual period? And is it regular or not? Any bleeding? Sorry, any painful period? Any heavy period or any heavy bleeding? No. So when was last menstrual period? Is it regular or not? Any painful period? Any bleeding or not? Or any spotting? Any bleeding or spotting between the periods? So again, when was the last menstrual period? Is it regular or not? Any heavy period, like any bleeding? Any painful period, and then any bleeding or spotting between the period or not? Okay, okay. For any female. Then, in some stations, like the patient who is immunocompromised, or the breast stations, not necessarily the breast stations, sorry, the patient who is immunocompromised, or the STI station, okay, like the gonorrhea station, the HIV station. Then, the morning after pill station. In some stations which can be related to the sex, really, you can ask sexual history, but not in all the stations you have to ask sexual history. For example, what is the point of asking sexual history when the patient is having chest pain? It's not a big deal. We will get to see that in a while. Okay, this is the history so far. Before moving to anything, you have to signpost. Do not. I do not need to practice with someone, and I notice that he's moving from the past medical history, and after finishing the family history, he will say, "Do you smoke? Don't do this." After the family history, always ask, "Let's have a quick review about your lifestyle. You smoke, you drink alcohol, and this and that." Okay, okay. Now we are done with some of data gathering. Okay, we'll move to the communication skills and the management in a while. Just give me 5 minutes break and we'll be back. Actually, we are still having 1 hour to finish our session. 1 hour ultimately to finish our session today. Okay, so just give me 5 minutes break and we'll be back. And who needs to do anything, you can take a break as well. I will mute myself only. Do not quit. You just mute yourself. Before forgetting, we are going to talk about the bird questions. What are the bird questions? Simply, the bird questions are the pediatric questions. Because in the pediatric question, you will not ask about the lifestyle. So the baby or the child definitely does not smoke. So in the bird questions, you are going to speak about bird questions. What are, in the pediatrics, you are going to speak about the bird questions. What are the bird questions? How to ask about them? B stands for birth. How was his birth? Number two, I, immunization. Is he up to date with hijabs? 3. Read book. Just ask this question. Are you happy with his read book? The mothers in UK, they know about the read book. You do not need to elaborate more. Don't be smart. Just ask, are you happy with his read book? D stands for diet. Diet. You will not ask about his diet. You will ask about, is he feeding well? Does he go to the loo more often? Or sorry, what about his loo, his poo, and his wee? Sorry. So for the D is a diet. D, tell me about his feeding. Any problem with the poo? Any problem with the wee? So those are the 3 questions for the D. D stands for diet, and usually with the diet comes urinary and bowel problem. So you will say, any problem with wee? Any problem with poo? So these are the birdie questions. You will put them in the pediatrics instead of the lifestyle questions, because usually the child did not develop in lifestyle yet. So you have to ask the birdie questions right now before or instead of the lifestyle question in the pediatrics. Let's move to some important things. Some skills that I need all of you to develop before going to the practice. One of the doctors, I think Dr. Fombi, I think, she was asking me, I need to practice with you after the course. Actually, all of you will practice with me after the course. All of you will be offered, because this is part of your fees, you will be offered 1 hour practice with me after the course, after the 15 days course. 1 hour containing 4 stations at least from each category. Like, for example, 1 mini-mental state, 1 history taking, 1 ethics, and 1 counseling. So I need to make sure that at least you know the right approach, how to approach the stations. And I would consider that all of the people who are coming out of here of this session or of this course, they are my students. So if any mistake you are making, this means that I have made mistakes in my teaching. Okay, which I do not accept. I accept feedback and review, but I do not accept that you are coming out of this course and repeating the same mistakes. That's why I'm going to check on everyone every day. For example, we will start our session from tomorrow. We will start our session 10 minutes earlier, because in the first 10 minutes, I need to ask everyone a question to be answered in 1 minute. For example, I will ask Dr. Zaid, for example, first thing, I will tell him, Dr. Zaid, tell me how to elaborate the cough. Dr. Zaid, Dr. Bina, tell me how to elaborate the tummy pain. 1 question, or sorry, 1 minute for each one. This will take us 15 minutes maybe, or 20 minutes. Okay, this is fair enough. I do not need more than this. Okay? Because that's why I will keep checking on every one of you. I'm sorry if everyone or if anyone is not focusing regularly. I am sorry, I would not let them attend, because this is a waste of your money before a waste of our time. Okay? If you really pay money and you are very willing, or you're very careful about your money, please make it worth. And inshallah, I'm pretty sure that it will work. Okay. So, number 2, we spoke about the data gathering, number 1. Number 2, actually, what will happen? I took the data, I gathered the data very well. But still, I do not need to be robotic. How to not be robotic? Let's demonstrate on myself. When I used to take history, I used to tell the patient, for example, the patient told me, I am tired. I told him, I'm so sorry to hear that. Are you comfortable to talk? Yes, doctor, I'm just feeling tired a little bit. Don't worry, it will take short. We'll do it as quick as possible and we'll sort it out for you. So please bear with me. See, I went far away from my data gathering. What is the data gathering here? When did it start? How did it start? No, this is not what I started with. I started with simple human things. For example, the patient is telling you she goes to the swimming class every other day. You will tell her, okay, what about your diet? No, I need you to tell her, for example, well, that's great. I'm sure you enjoy this. She'll tell you, yes, doctor, it's fun. And that's why I'm keeping healthy, balanced diet. See? You pushed her to tell you about some other finding, and actually she liked your encouragement to her. She got more excited to tell you and open up to you. These things matter? Yes, these matter. In the worst cases, if you apply these things, you will gain at least 3 or 4 in each station. besides some effort, you will gain very good. Those are the interpersonals. Those interpersonals you have to play on, rely on them. Those are the really good and strong points for any plabber. Do not lose them. And history taking as well. By the method I'm teaching you today, you are able to tackle any history taking question. You will get at least in the brand new station which you do not know, you can score at least 2 in the data gathering in it. Okay. So we spoke right now about the some skills. Number 2, we finished our history taking. The next portion of the data gathering is the examination. Why do many people forget about the examination? After finishing the history, you will tell the patient, thank you for answering my questions and your cooperation. Right now, I'm going to examine you. I'm going to check your vitals, including your blood pressure, your pulse rate, your breathing, your body temperature, and your oxygen saturation. You have to verbalize the vitals. Okay? I'm going also to have a look at you from head to toe. Then you will mention the relevant examination. After the general physical examination, always comes the relevant examination. For example, in some stations, you will do chest examination. In some other stations, you will do abdominal examination. Do not say, I'm going to do abdominal examination. No. The examinations and investigations and management, they need to be in patient words. Okay? They need to be in patient own words. Do not forget this. For example, I'm going to examine your tummy. Then, after the examinations, usually the examiner will give you finding. Now move to the investigations. I'm going to do some investigations as well. Here there are some scenarios or some two possibilities. If the examiner keeps quiet, or if the examiner asks you which investigation structure. If the examiner keeps quiet, it means that the examiner needs you to tell the investigations to the patient after disclosing the management plan, which means that the examiner is not interested in listening to your investigations because there is no findings to the investigations. So he needs you to say it to the patient after disclosing the diagnosis. Okay, Dr. Murad. Dr. Murad, you will say that I'm going to check your vitals or I'm going to have a look at your observations, including your blood pressure, your oxygen saturation, your body temperature, your pulse rate, and your breathing rate. The 5 vitals. You can say vitals, but you have to explain it after them. Like, for example, do not say, I'm going to check your vitals and pause. No. Say that I'm going to check your vitals, including 1, 2, 3, 4, 5. This will take you exactly 3 seconds. It's not a big deal, okay? But just mention them. Why? Because actually in some stations, the examiner will not reply to you till you explain the vitals. For example, in the pulmonary embolism station, the patient or the examiner will not tell you about the oxygen saturation unless you mention it in the vitals. So please mention the vitals in each station. Mention them and explain them in details, in a lengthy way. Okay, now move to the investigations. I said that if the examiner asks you which investigation, you will say the initial investigation, like the bloods and urines. Bloods, okay? I said bloods, not blood. Bloods mean that the routine bloods, like full blood count, kidney and liver and thyroid function test, blood cholesterol and blood sugar as well. Those are the routine blood that should be done in any patient. They are mostly done in any clinic. And the urine, which is the urine analysis or urine dipstick. This if the examiner asks you. In some stations, actually, the examiner also, or you are supposed to do ECG, and some other stations you are supposed to do chest X-rays. Usually, those are initials, which means that they are like very easy to be done. But do not mention, for example, in the investigations, like I'm going to do MRI right now. Is it sensible? Do you go to the MRI before doing at least X-ray on the back or X-ray on the spine? So when the examiner asks you which investigations, please say the initial or the simple things. But if the examiner did not ask you which investigations, this means that the investigations are not important now for your diagnosis. So you will say them after disclosing the diagnosis to the patient. How? Let's see. From what you told me and from our assessment, it seems that you are having a condition we call obstructive sleep apnea syndrome. What is this, doctor? Well, from its name, apnea means cessation of breathing. Sleep means that it happens during sleep, as you told me. And obstructive means that it's due to obstruction in the airway. And that's why you're having this shortness of breath, especially during sleeping. You will find in all the scripts the obstructive sleep apnea is explained at least in 3 or 4 lines. But this explanation is very wise. I'm telling him that apnea means cessation of breathing, which happens during sleeping due to obstruction in the airway. Oh, doctor, why did I get it? Okay, so let's agree on something. You will disclose the diagnosis at the beginning. After disclosing the diagnosis, you will pause. Why you pause? Because you need the patient to ask you, what is this? To maintain two-way conversation. I noticed that some people will go like, from what you told me, it seems that you are having a condition we call chest infection. No, you are having a condition we call PID, in which there is an infection or inflammation in the tubes connecting the ovary and sometimes the uterus. And this usually happens due to a bug which entered your uterus actually due to the use of coil. See, the patient now is lost. The patient has lost track. Do you think any patient in the world can bear you while saying this? I don't think so. So please, when you are telling the patient something, give pauses. In the management from now on, if I hear someone who's telling me a management without giving pauses, at least even if I'm not talking to you, for example, if I'm telling Dr. Bina, tell me, Dr. Bina, what is the management of the SAH, the subarachnoid hemorrhage? And she tells me it is a condition in which there is a bleeding on the brain due to rupture, due to rise in the blood pressure. And did I ask you why did this happen? No. I asked you what is this? I did not ask you to explain it. I just asked you what is this? So it is a condition we call subarachnoid hemorrhage. So now, number one, you'll ask the patient, okay, thank you for bearing with me or letting me examine you, because usually this comes after the examination part. Okay, thank you for letting me examine you. Do you have any idea what's going on? This is the idea. We ask the patient, do you have any idea what's going on? No, doctor. Well, from what you told me, it seems to me that you're having a condition we call pulmonary embolism. So, number one, idea. Number two, give diagnosis. Then pause. Why you pause? To maintain two-way conversation, because it's called patient-centered consultation. You have to give the patient all the chance to ask you. Even if you are running out of time, yes, even if you are running out of time. Why? Because if you say everything in the management without letting the patient ask, this means that you will get ultimately two, because you turn it into one-way conversation. But if you say, or if you let the patient ask you about everything, even if you do not tell the patient about everything in the management, you will end up getting three above. Okay, give diagnosis, pause, let the patient ask you. Now you explained. The patient will tell you, what will you do to me, doctor? In the management, usually you have, number one, you have to speak about 5 portions or 5 points. Number one, admission, if you will admit the patient or not. You can say it like, we are going to keep you in the hospital. Okay. Number two, senior review or not. You have to determine whether to ask senior for review or not. How will we determine that? I have a good idea. Why don't we involve the senior in any emergency station and any drug change station? You have to involve the senior in anything like this. Any emergency or any unwell patient and any drug station, you have to involve the senior, because these are big decisions. They need to be prompted by someone who is in bigger position. So number two, senior review. Number three, symptomatic treatment. What is the point of treating the disease itself while letting the patient die out of pain? Okay, so symptomatic treatment, number three. Number four, definitive treatment, which is differing from one disease to another in the PLAB 2. Number five, if you ever have time, you can mention the safety netting and warning signs, if you have time. Because in most of the history-based stations, you will not have time to mention them. So let's have a quick review. Number one, idea. Number two, disclose diagnosis. Number three, give pause. Number four, explain diagnosis. Number five, after that, what will you do to me, doctor? You will tell him the management. But if the management, when you are saying it, You will always you will not say more than 2 sentences in one go. For example, we need to keep you in the hospital to have a closer look at you. Then pause. Why? Because mostly the patients in PLAB 2, they are reluctant or they are against the hospital admission. Why? Because you know this. Usually, no patient wants to stay in hospital. So you will say, we're going to keep you in the hospital and then give pause. After that, if the patient accepts, you will tell him that I'm going to ask my senior to come and review you, and we are going to give you some medications. Would you like me to tell you? Yes, doctor, tell me. See, now I said no more than 2 sentences, and I involved the patient with me. Okay? Okay. I said the management plan, good. Now, okay, doctor, thank you. Do you have any other concern? This question must be asked when you are saying the management or when you are like explaining to the patient what we are going to do. You can ask him, are you following me? Or you can ask him, do you have any further concern? But do not ask the concern thing while you are saying the management plan. Why? Because sometimes it can be taken as you have finished your plan and you are waiting for other patient concern for the other concerns by the patient. So it's better to say this word. Do you have any concern after finishing your management plan, after finishing the treatment? For example, you finish the treatment plan right now. Ask him, do you have any concern? So the concern comes after telling the treatment. Okay? Okay. So again, after hospital admission, we give pause, and the concern comes after finishing the treatment. Right? Okay, let's speak about two important things. In the cancer possibility and in the cancer disclosure. In cancer disclosure, I consider it as breaking bad news, and we will speak about this in a while. But in the possibility of cancer, for example, in the mesothelioma station, I'm going to tell the patient, it seems to me that you're having a problem in your lung. Oh, doctor, what is this? Well, actually, at this moment, it's difficult to say. That's why we are going to do some investigations. Now you will say the investigations in details. Doctor, why all this? Is it serious? Yeah, I know why you think so. So if the patient asks you, is it serious or is it cancer? The first question to be asked, hey, I know why you think so. Doctor, because you told me a very big list of investigations. Or sometimes he can tell you, doctor, because my cousin has got cancer. Oh, I'm so sorry for your cousin. How is he coping? Doctor, he's fine. Oh, that's great. Well, actually, at this point, as I told you, it's difficult to say. We need to run further investigations. However, cancer could be a possibility. This will be said in the stations in which there is a possibility of cancer, like there is weight loss, there is deterioration of the condition. But in some other stations that there is no other clue of cancer, for example, if the patient is having like tiredness, you cannot say that cancer is a possibility. You can say that from what you told me and from my assessment, it seems to me that you do not have symptoms suggestive of cancer. However, we need to do further investigations to find out the cause or to reach the bottom of this problem. So if there is a clinch or if there is like a clue to cancer, you can say to him cancer is a possibility after saying that we need to do further investigations. But if the patient did not give you any symptoms or any suggestions of cancer, say that from what you told me, it seems to me that you are not having symptoms suggestive of cancer. However, we need to do further investigations to find out the cause. Okay? Okay. This will be clear in that why we are teaching, because there are like around 10 or 15 stations which you will encounter this challenge. Okay? Two of them came new, which is the leukemia and the ovarian cancer. Okay? We will speak about them inshallah later. And by the way, guys, regarding the new stations which keep coming recently, don't worry about them because I will include them in our course days. Like for example, when we are speaking about the tiredness stations, I can encounter one of the new stations with them, like related to the tiredness. And when we are speaking about the pediatrics, definitely I will include the autism. And when we are speaking about the ethics, the colleagues, we will encounter social media. And regarding the counseling as well, I will include the chlamydia. Okay, so these stations will be included in our daily discussion. Okay, actually, some people I know that some people are relying on this course as like complimentary, but inshallah, when we are done with it, you'll find that it can be a full course apart from the mannequin. I cannot provide you with the mannequin, but I will give you definitely the tips about how to do the examinations. It will be one day for the combined station. Okay, we'll speak about them and give quick tips about the examinations. Okay, okay. Dr. Yasmin is asking me a question about what about follow-up and offering leaflet. Dr. Yasmin, the problem is that in the history-based stations, you will not have time to finish the management itself. So how come I do not finish the management in my hand, which is in the present, and I speak about the future leaflet and the future follow-up? I hope you got my point. But your point is very valid when it comes to the counseling and to the ethics stations. Why? We're going to speak about them right now, instantly, in 2 seconds. So now I'm done with the history-based stations. The management is usually the most challenging part in the station of the history-based. Why challenging? Not because it's hard, but because you are having limited time in it. You are barely having 2 minutes and a half or 3 minutes ultimately in which you have to address the patient concern and maintain two-way conversation. And you have also to remember or memorize what you have studied. So it's a little bit challenging. However, believe me, it will be the easiest part for you if you follow the approach I'm telling you in the next few days. You will be remembering the whole management in few points, with some stop phrases and some sentences that you will apply to each answer. Usually the scripts are quite long just because they are putting and copying and pasting the same sentences in every script. But your mission is to remember only 4 or 5 points from each management and go. Like you used to study the management for any medical disease in your study, in the college or in the school or whatever. Okay? Okay. Now, let's come to the counseling stations, my favorite stations actually. For the counseling stations, I need you to follow this approach, which I will send to you today, and I said about it many times before. Counseling stations are challenging for one reason, because you will be the interviewee. You're not the interviewer. You'll be asked many concerns by the patient. Okay? Perfect. In the counseling stations, you know what I need from you? I need from you only to limit your data gathering to 3 to 4 minutes ultimately. If I practice with any one of you and I notice that they are taking data gathering in history stations, in counseling stations, they are taking long in data gathering, they will pay a fine. Because I'm really excited. I need to collect as much fine as possible after this course. So for everyone, you'll be having like maximum trials. If you cross the 5 trials, you will pay £5. The 5 mistakes, you will pay five. No, if you cross 5 mistakes, you will pay £10. So I'm making my own list right now, and if you are really caring about your money, please try to focus when you are asking me or when you are talking to me. 5 mistakes are allowed. Why people fail counseling stations? For 2 reasons. Number one, they take longer history, very long actually, not only long. Number two, um, they cannot express themselves because in the counseling stations usually you have to give many advices. You have to maintain two-way conversation as well. Something very important, it is called counseling, which means that you have to check the understanding of the patient and involve them. What if you did not involve them? You will barely score one, particularly in the counseling station. Why? No, I mean one in the management. Why particularly in the counseling? Because counseling station is management in disguise. It is a management, but in disguise. So you have to maintain two-way conversation. No way, you have to maintain that. Okay. In my attempt, in my second attempt, the last time, or my second attempt, which was like 2 months ago, uh, I scored in all the counseling 10 and 11. Two of them 12, two 11, and one 10. And the one who I scored 10 in it, I made a mistake actually. And I will say it to you in a minute. So, In the counseling station, simply, you have to maintain two-way conversation. You have to be concise in your history taking. What is the approach for counseling stations? I need you to enjoy the counseling stations. Counseling stations is the only station in which you can relax. You will not have a tough time from angry patient. You will not be bound to time while taking history because it's a very easy station. When you are stuck, you can open the BNF. When you are stuck, you can check the senior. So counseling stations are usually a gift. You'll be happy if you have counseling and ethics station in your exam rather than history taking and SIMMAN. SIMMAN, by the way, will be explained in one day. I have my own recordings for it and it will be offered to you. But you will listen to the recordings before our day, and our SIMMAN day will be pure press. It will be the last day of, the day before, the 14th day of our course, inshallah. Okay, so for the counseling stations, number one, I need you to greet yourself. The counseling stations do not be stressed, which means that you have to be smiling. You have to be very good in the counseling station. You have to be yourself. You have to be yourself. Like if you are talking to your relatives or if you are talking to a normal patient in your clinical practice. Excuse me. So in the counseling stations, number one, you will greet the patient with a big smile. Number two, you will build a good report. But good report is very important for two reasons. Because the better you report, the easier will be your management. Patients are very skilled. They are more experienced than you. They know how to trick you and how to deceive you. If this patient likes you, and usually this can happen, and this happened to me, if this patient likes you, they will not give you many concerns. They will give you 2 or 3 concerns. This is very useful because this means that you already took your mark after addressing the patient concern and after building good rapport, of course. How to build a report? I greeted myself to the patient. Number two, how can I help you today? Or some people prefer saying that I could see from your notes that you came today, for example, for diabetic checkup. Oh, yes, doctor. Or if you ask them, how can I help you? He will tell you, doctor, I came today for my diabetic checkup. Okay. Now he came for diabetic checkup. Why don't you encourage him? You know that follow-up is not good or I mean it's not maintained and it's not like it's not kept or it's not like not all the patients are regular with it. So you should tell them, well, that's great. You did the right thing by coming today. I'm glad to receive you. So now you will take some history from him. If he's coming for follow-up, you will take some elaboration of the relevant disease. For example, diabetic review. Now you elaborate diabetes in details. If the patient is coming here for counseling of the drug station, you will ask him about the drug in details. For example, since when have you been taking the drug? Okay, and do you take it regularly as prescribed? Have you experienced any side effects? Any recent change in the dose? Okay, this is very enough. So number one, history of the relevant presentation, which is drug or disease or risk assessment or whatever. What if the patient is coming because he worried about risk of developing, for example, risk of developing stroke? For stroke risk assessment or any disease risk assessment, you have to ask number one about symptoms of the disease. For example, you will ask him if he already developed one of these symptoms or not. Have you ever developed any tingling or numbness, any facial weakness or drop? So number one, ask about the symptoms of the relevant disease. Number two, in any count, so now you picked up the relevant history, number one. Number two, in any counseling station, you have to ask the maftosa or the past medical history. This is usually the most important part of your counseling because usually the risk assessment or any counseling station, it is based on either the chronic medical condition or the recent health or the family history. So you will ask the PMH very carefully, okay? Because this is part of the risk assessment. Number three, move to the lifestyle. Lifestyle is very important in counseling. Actually, it is half of the management in the counseling stations. because you will give advice about lifestyle very quickly. After the lifestyle, you can ask about any stress. Very good in the counseling stations, because it's usually like very good question and very like we call it like mind ease question, to break the stress from yourself and to let the patient talk as much as they want. Now, move to the examination part. You can examine any patient in PLAB 2 unless the task tells you do not examine the patient. Examine any patient in PLAB 2 unless the task tells you do not examine the patient. After that, move to the investigations. Initial investigations only. The examiner will ask you again. If he needs to listen from you, he will tell you which investigations. And if he does not want to listen from you and he keeps silent, now we'll move to the management. In the management portion, you will speak about number 1, thank you for bearing with me. From what you told me, it seems that you are. Now it differs. The patient can be at risk of developing a disease. So you are at risk of developing this condition. Do you have any idea why? Now you will explain the reasons why he is at high risk from your history. For example, because you are smoking, you are having family history, you are whatever. This is for risk assessment. And for other counseling stations, for example, he's coming for diabetic review. Well, from what you told me, it seems that your diabetes is not well controlled. Why? Let him ask you why. Because you have loss of sensation, for example, over the below the knee, and your blood sugar is on the higher side in the past 3 weeks. It's 3 months, sorry. So you will disclose number 1. Number 2, ask about the idea, and then explain why he is at high risk or why this diagnosis or why this finding. We will say them in details, but usually, number 1, history taking. Number 2, history taking includes relevant thing, PMH or Maftusa number 2. Number 3, lifestyle. Number 4, examination. Number 5, disclose and ask about the idea. What if the patient asks you this? What if this is like stroke risk assessment station? You will tell him, well, from what you told me, it seems that you are at high risk of developing stroke. Do you have any idea why? I'll tell you why, doctor. Now you explain the reasons, which he has from your history taking. Doctor, what shall I do? Now you can ask him, do you have any idea what is a stroke first before proceeding? Why? Because you will give him advices according to his understanding. What does this mean? Actually, this is a discrepancy here. You can start your management by saying, thank you for bearing with me. You came because you were concerned about the risk of developing stroke. Do you know first what is stroke? He will tell you, yes, doctor, I know about it. Or he will tell you, no, I don't know about it. So you will have to explain it to him. After explaining, you will tell him that, actually, I'm afraid that you're at high risk of developing it. Why, doctor? Because you have 1, 2, 3, 4. So let's start your management by saying this. You came here because, for example, of diabetic checkup, and your diabetes is not well controlled. So we do not ask about the idea usually. We do not assess the patient understanding of the disease if he's already diagnosed with it. But if he's here because of high risk of developing a disease or if risk assessment station, you will have to ask him about his idea or his knowledge about this condition. Because this is the first time you take history or this patient is asked about this condition. So do not forget to ask about the idea in the beginning of the disclosure. And this will be provided to you in the short notes when we speak. Counseling sessions will be the easier thing for you, I promise. Number 2. Now we explain the risk. Now let's say what we can do. What I can do for that, doctor. There are some things that we can do and some other things that you can do. What would you like us to start with? Always remember this sentence when you are disclosing the management or when you are speaking or giving advices. Some things that we can do and some other things that you can do yourself. What would you like us to start with? Usually, as a medical team, we can do follow-up and investigations. The patient can always do change in the lifestyle. So what we can do for the patient is follow-up and investigations and medications as well. what the patient can do changed in the lifestyle. How to speak about the lifestyle? Number one, being an overweight can lead to this problem. You told me that you are eating everything. I'm afraid to tell you that you have to maintain healthy, balanced diet because putting on weight can put you at high risk of developing this condition. So what can I do? You will advise him about like maybe steamed or grilled food, better than fried food. Homemade food is much better, even if you freeze it. Mediterranean diet, which contains olive oil, is very healthy. Too much salad, the 5 portions of fruits and vegetables, like these diet advice. But please, guys, what if you are running out of time and you cannot speak all these advices? You will give him one or two advices, very enough, and after that tell him, however, we can also refer you to a dietitian to set you proper diet plan which like matches your preferences. This is very good because you will not have time and at the same time you cannot overlook the dietary advice. So please mention about the dietitian in some time, but not every time, but at least if you're running out of time and you still have to speak about some other things, don't forget to mention about the dietitian. This is number two. Number three, in the follow-up. In the follow-up, you will speak about the rigor investigations that we will do and the medications that we are going to give them. So your management is number one, things we can do. Number two, things that they can do themselves. Okay, in the end, you can give safety netting and warning signs. For example, if the patient is presented for stroke risk assessment, your safety netting and warning signs will be that he should attend the follow-up regularly, please. And if you ever develop any facial weakness or any weakness in one side of your body or any slurred speech, come back to us. Warning signs are the warning signs which can be related to the relevant presentation or the relevant disease at risk. Okay, so number one, history taking. Number two, past medical history taking, including the relevant or the presenting concern. Number two, past medical history. Number three, lifestyle. Number four, examination. Number five, assess about the idea or the knowledge about the relevant condition. Number six, explain he or she is at high risk or not. Number seven, the changes to be done. Some things that we can do and some other things that you can do. Okay, do not speak more than two advices at one go. Always have pauses, maintain pauses. Check the patient understanding by asking them, are you following me? Do you have any concerns so far? Am I clear? If I was not clear at any point, please let me know and stop me. Okay, this is a very smart way to cut your time short and at the same time to show the patient that you are not ignoring him, no matter how you are speaking fast. Okay, okay. Of course, there's exceptions, at least 5 to 10 stations exceptions. Not 10, no, actually 5 or 6 stations exceptions in the counseling stations, which will be discussed in details in our course. Let's move to one of the most challenging things in PLAB 2, which is the ethics. Just give me 1 minute. So, sorry for interruption. So now let's speak about the ethics station. The ethics, which is the ghost for PLAB 2. Many people, when they know that they are entering an ethics station or a cubicle ethics station, they start trembling and shaking. And actually, some people may consider that the ethics station are the stations that they are going to fail, no matter what they do. This is not true. Actually, the ethics station, though they are the most challenging, but the key to the ethics station is to keep calm. Why calm? Because you are going to face a tough time, either with an angry patient or breaking bad news or stubborn colleague or angry senior can happen. So in the ethics station, the core is to be calm. It is like I call it like psychological stability test. Yes, it is psychological stability. Why psychological stability? Because I noticed that you are practicing in the academies, your colleague or your partner is not an angry patient at all. He does not give you like a genuine reaction. So you will go to the GMC, it will be the first time for you meeting a real angry patient. And guess what? A British angry patient, which is even worse than any other angry patient. So what will you do here? Let's agree on something. I will divide the ethics sessions for you for 4 sections. Number 1, angry patient. Number 2, breaking bad news. Number 3, dealing with a colleague or a senior. Number 4, it will be a worried patient. Okay, the worried patient will be like the domestic violence, like the patient who is going to change the counselor, like the patient who needs like the emergency pill. Okay, okay. So let's speak about the angry patient. In the angry patient, I'm going to give you a few tips. The patient supposes the patient is angry. In any angry patient, let the patient talk. Usually in the ethics station, the more you talk, the less you will score. You have to be as silent as a stone in ethics station. Cut your sentence short. Long sentences can piss me personally off. So what about an angry patient? They definitely will be pissed off more. They are already not interested in what you are saying. So do not make it hard to yourself and to them by speaking more. Okay? For example, I can see that you are quite frustrated. Please accept my apologies on behalf of me and all my medical team. I will definitely talk to them and find out what happened. See, this quite slow way, it is, and by the way, I'm validating his concern with my face. When I'm explaining the ethics stations to you, inshallah, in 4 or 5 days from now, you will see my face while I'm saying the sentences. And I may ask you even some awkward things. I may ask you to come to go and train in front of the mirror. I will ask every one of you to show me his facial or her facial expressions when they are speaking at least for 1 minute. I noticed that most of the people face the ethics station because of 2 things. Number 1, lack of expression. Number 2, mask face. Why mask face? It's not something personal. It's usual. Because when you are under exam setting, you will be stressed. So you will be mask faced. I do not need you to do this. It is psychological stability test. If I am testing you psychologically and I see that you are reacting naturally, definitely I will pass you. But if I see that you are stammering and you are losing eye contact and you are giving faces, I will not be comfortable with you. So the angry patient lets the patient speaks too much. Number 2, always validate their concern. When he tells you that this can't happen, do not justify yourself. For example, if he tells you, how could this happen? How could this happen? Do not answer him like, actually, my colleague forgot to label the sample. Don't do this. When he tells you, how can this happen? You tell him, I can really imagine how it can be frustrating or how it can be upsetting. I will definitely talk to him to find out what happened. Please accept my apologies on behalf of me and all my medical team. Definitely, Dr. Ella, I will explain it in the ethics session. It will be the nicest and the most enjoyable session in our course, inshallah, the ethics and the counseling. Okay, so what happens? What happens is that actually in the angry patient, I notice that the people, when they see an angry patient, they lose track. No matter how long you are living in UK, or no matter if you are English speaker or not, you will be like, I'm really sorry. Please accept my apology. This way, okay, you can be having very good command of the English language, but this way actually it may sound that you are stammering, you are worried, you are anxious. And I told you in the beginning, it is psychological stability test rather than station. They are testing your stability and your ability to communicate and convince the angry patient with your point of view. Because actually, in the clinical practice or the medical practice, you'll be having many angry patients. You know, the rich people, they do not like anything. So it's very important to know how to tackle them. Let them speak as much as they can. Always validate their concern. Show them they have rights, the full right to be angry. Number three, apologize whenever possible. Please always apologize. Number four, offer to them solution. So the solution does not come in the beginning. Solution comes after apologizing and validating. Number five, if the patient is still like insisting, you will offer the instant form. And actually, you will offer the instant form. As a medical error happened, you will offer instant form. But if the patient insists on complaining, you will guide him toward the pulse. What if the patient did not bring the complaint saying? For example, the patient did not tell you that I want to complain. Do not tell them about pulse. If the patient did not tell you I want to complain, do not bring pulse because it will look awkward. You will look too scripted. For example, if I'm not interested to watch a football match today, and you're telling me, the football match of today is really nice. You have to watch it. It will be like an interesting game. Doctor, I told you I'm not interested in watching a football. I'm not even a footballer. I'm not a fan. So why would you bring something the patient is not interested in? And by the way, pulse is a big thing. Pulse is not an easy, it's a formal complaint. So do not bring it unless the patient insists on complaining. In the end, usually it is the end after everything. So regarding the angry patient, the core is to listen. Listen to the patient all the time, even if they speak for 5 minutes. You are taking marks for all this. What about the breaking bad news? You reassure the patient, number one, like I'm here to talk to you and address all your concerns. I'm sure that you're having a tough time. Okay, so can you have a seat, please? I am Dr. XX, one of the junior departments here. Okay, and we or she will tell you I am XX. Nice to meet you today. So can you tell me what happened? She or he will tell you the whole story. After that, you keep asking some questions like, for example, and what happened next? What next? What did you do? Like these questions to resume or to cope with the full story. After that, you will tell them, thank you for that. Actually, your husband came here because he's having this headache for which we did some examinations and some scans. One of the scans was CT scan. Has anyone told you about the result of the scan? Do you have any idea what's going on? Actually, I don't have encouraging news. Would you like me to proceed? The CT scan shows that your husband is having bleeding on his brain. Pause. Or you can simply say bleeding on his brain, which we call rupture brain aneurysm. Now you will disclose what's the result. Oh, there's much noise. Seems that car horn is stuck. Okay, wait. Hello. So you will tell the patient that the CT scan showed bleeding in the brain, which we call rupture brain aneurysm. Pause. Respect the patient's feeling. They are going usually to be in shock right now. What is this, doctor? It is a condition in which the aneurysm, which is outpouching or pouching of the blood vessel in the brain, ruptures. That's why the bleeding flows inside the brain layers. Oh my God, why did this happen to him, doctor? He was just having hypertension. He was absolutely fine. You will tell her that I'm afraid that this is one of the complications of the uncontrolled blood pressure, especially in the old age. Doctor, is he going to die? Now, you will not tell her, I hope it was wrong. No, don't say this. You will tell her that we are doing our best for him. A team of expert doctors are looking after him right now. Doctor, is he going to die? I'm afraid his condition is terminal, and we are not expecting any improvement. So number one, you will tell her that we are looking after him. We are doing our best to look after him. And number two, when she insists on asking you, you will tell her that I'm afraid that his condition is terminal and we are not expecting any improvement. Or you can play it on your way. For example, you can say, I wish I was mistaken, or I wish I was wrong, but I'm afraid that his condition is terminal. You can say it in any way, but just tell her, do not tell her like, I'm afraid that he's going to die. Don't do this. Don't be too frank. Say it in a nice way. Respect the patient's feeling. Say that we are not expecting improvement at the moment. We are not expecting him to get better. Play it the other way around, but don't say that unfortunately yes he's going to die. Don't say this is too harsh to someone feeling. Okay? Okay. Regarding the breaking bad news, you have to break in layers, usually. Okay? These layers we talk about. Number one, we did CT scan. Do you have any idea about the result, or has anyone told you about the result? Actually, I don't have encouraging news. Would you like me to proceed? Would you like anyone to be by your side? You can ask this question or you cannot ask it, it's fine. Okay, now you can say the result. So please make sure that you say it or break it in at least 3 layers. 3 layers are very good. Do not do it, by the way, you can do it actually in 2 layers as well. I noticed that in some clinical practice or any videos, they can do it in 2 layers as well. But you know, the best thing to do is the 3 layers. You know why? Because this station is already short and you still have time to cover everything. So take your time and be slow. And in the facial expressions, you have to be a little bit sympathizing. Not little bit, it is you have to be very sympathizing. This is someone who is going to lose a relative. So God forbid, God forbid, God forbid. Dr. Yemi will speak about this right now. If God forbid, if you are having the same situation, you will hate the doctor who will speak to you boldly and frankly. At least shows in some sympathy and empathy and like quiet validation. This is very important. You cannot imagine how this will give you marks. Dr. Yemi is asking one question about the data gathering. Actually, Dr. Yemi, I was asking you in the beginning, or I was telling you, the data gathering will be in the form of, can you tell me what happened? And then what next? And then what next? In these stations, usually they will tell you the medical history of the patient. For example, she will tell you, doctor, um, you know, my husband had this and that while watching TV. He was absolutely fine. He was not having anything. He was just having high blood pressure. I mean, it was controlled, doctor. I do not know what's wrong with him. So it's up to you. Here, it depends on the patient. Some patients will insist to you that you have to tell them what's wrong with their relative. Some other patients will let you ask. What happened to me? The guy, he was not a good simulator at all. It was the first time, it was a breaking bad news as well, but it was like intracerebral bleeding. It was quite a little bit of trust. So I was telling him, for example, how was his health recently apart from that? Did he have any headaches in the past few days? What about any blurry vision? Does he have any medical condition? Does he take any medications? Then I asked him, does he smoke? Does he drink alcohol? Okay, those were the questions that I asked. Very enough. But in some stations, especially in the old ones, like maybe the Rupture-Berry aneurysm or Joshua or this and that, you cannot take some data gathering or much data gathering. So it depends on the patient. If the patient lets you, which management, Dr. Doha? What is the management of the station? In the breaking bad news, there is no management. The breaking bad news here, usually in this station, it will be palliative care with some other concern. Like, can you shift him to the ICU? Can you do CPR? Can't you do surgery? Those are the questions to be asked. There is no management, it's terminal condition. The MDT has decided on palliative care. Data gathering, Dr. Yemi, again, in any case, in PLAB 2, and good that you reminded me, in any case, in PLAB 2, wait, I will tell you right now, Dr. Daha, and please, one mistake that you guys are making in PLAB 2 is that you are comparing the other people says or what the other people said, and you are building your marks on them. Okay, let me answer Dr. Yemi's question because this is very good. Actually, he reminded me of that. I used to like I was about to explain it in the next stage because it differs from one station to another, and actually it differs from one simulator to another. For example, in the same station there can be two simulators. One of them will push you toward disclosure, and the other one will let you ask no matter what you do. So let's agree on something. Number one, if the patient insists on you for the first time, you will still ask some history. But if the patient insists on you again, so the second time you will move to disclosure. So first time you can ask, second time move to disclosure or move to the concern directly. You don't have any other option. Okay? So you can ask whatever you wish. But if the patient insists on you for second time, please leave anything and go to the patient. Concern. Dr. Duha was telling me, she said that one of my colleagues told her that and she got two. Dr. Duha, you know what? I'm sure that if I ask the 22 participants now, if I ask everyone to tell me about the steps of palliative care, the 22 people will say it in 22 different ways. One of them will say it in a very fluent way, but they will not involve the patient. One of them will say it in a very fluent way, okay, but they are not, for example, they are very fast. So this means that they are not checking the patient understanding at all. Some of them may stammer in it, in the palliative care. Palliative care will take you barely 30 seconds or 45 seconds to say. Some people may say it in maybe 1 minute and a half. This shows that you are not quite aware about the palliative care, or that you are stammering. So generally, there are many things to consider while asking someone about their marks and about what they said and how they say it. Our course here is not to teach you the knowledge, the full knowledge. It is part knowledge, but the most important thing to focus on is how to deliver the knowledge in this course. Because I'm sure that at least 75% of you, they have attended academies before. So it's pretty obvious that it's not the mistake of the knowledge or the mistake of the academy. It is here the mistake or the problem of how to deliver your information, which you will not be taught somewhere else. Because usually they focus more on the knowledge rather than the quality of how to say. Okay, so this is the breaking bad news. Number 3, dealing with a colleague. Dealing with a colleague, I consider it actually one challenging as well, but it's easy. You know why? Because usually I used to start my station with building a rapport. How to build a rapport? In your colleague. Hello, I'm Dr. X, one of your colleagues here in the department. You are John, right? Yes, nice to meet you, John. How are you today? How was your day? Did you have any patients waiting for you? Apart from that, how is your study or how is your work ground going? How are you coping with the work here? Everything's all right? Do you need any help so far? Like in any patients or in any duties or any some cases which are not clear? This is the report and you can build it in your own way. This is very important. This actually will affect your dialogue or your conversation with him in a while. If you build a very good rapport with him, he's more likely to be more open to you and more comfortable to you. Tell me, isn't this what happens in real practice? When you see someone who's talking to you who's very serious and some other one who's trying to convince you, but he's very open, he's very friendly. From whom will you accept the point of view easier? Definitely, you will accept the point of view of the friendly one because he's advising you for your own sake. He is not judging you. He is not blaming you. He's just advising you for your own sake. So the report is very essential in dealing with your colleague. Number two, you will tell him, for example, actually, I'm a bit concerned about something. I need to share with you. He will tell you, yes, doctor, tell me. Now you can bring on the issue. Usually you will be reluctant in the beginning. You will tell him that actually I'm not the only one who see this, or I'm not the only one who witnessed this. The nurse colleagues have witnessed it too. Now he will be concerned. If your colleague try to flip around, or if your colleague is trying to turn the whole thing around against you, for example, he will tell you, oh, doctor, you also drink. I'm sure you also tried sniffing cocaine once. You will tell him, Jack, please do not take it personally. I'm not here to, we are not here to judge you or to blame you personally, Jack. I'm just having this talk to you to reach the best possible thing for your sake. I'm sure you are one of the best doctors here, and that's why I'm having this talk to you to prevent any problems. Some people used to answer, like for example, if your colleague is telling you, you also drink alcohol. Some people used to answer, but this conversation is about you, not me. Well, this answer, I'm having a problem with this answer because this is quite formal. So how come you are talking to your colleague in a nice way and suddenly you turn formal? And he may be even an FY2 like you. So you are in the same position. So you can simply say, tell him that please do not take it personally. I'm not here to judge you. I'm talking to you for your own sake. So the core of talking to your colleague is to show him that you are really caring about his sake. You are not here to blame him. You are not here to scold him. You're here only to talk to him as a colleague. Okay? Usually they will open up to you at 3 or 4 minutes. After opening up, you can ask some questions about their lives. How is your life going? Do you have any problems? Whom do you live with? Like normal social exploration just to make sure that they do not have any reason behind their behavior. Then we will talk about the complications or the implications of what they are doing. This we call a SPICE protocol. What is the SPICE? I will write it in the chat right now, at least before sending you how to do that. SPICE protocol. Okay, what is a SPICE protocol? Excuse me, guys, wait. SPICE, SPICE protocol. SPICE means that number one, S, number two, P, the patient safety, okay. Then the initiative, then escalate, then final thing is support. The S number one is gathering data. How to gather data? By what I told you, with report and asking some social history. Number two, patient safety. Number three, initiative. Initiative means that I am going to check on the patient that he had seen. Okay, and then the S is support. The final thing is support. So number one, gathering data. Number two, very important, to patient safety. Patient safety is to tell your colleague that what you did is wrong. I'm afraid that will have some implications in your future. How? For example, alcohol can lead to sometimes like some strange behavior and some problems with coordination and balance as well. And I'm sure this will affect the patient safety. You agree with me? Yes, doctor, you're right. So why don't we, so tell me, have you seen any patients before today? Have you seen any patients today? Have you prescribed anything? Okay, just I'm going to tell you, I just need to tell you that I'm going to check on the patients. Doctor, are you double checking on me? Please don't take it personally. Please accept my apology, or please don't take or don't think that I'm going to double check on you just to ensure our patient safety. And I'm sure you agree with me that we should not let any chance for our patient safety to be compromised. So whatever the patient or the colleague will tell you, you always have reason to justify yourself. Then escalate to the senior. You're going to tell him, so I'm also encouraging you to tell our senior about that. Are you going to tell the senior about me? Well, I'm just encouraging you because they are our seniors and we work under their supervision and they deserve to know about everything. And I'm sure they will help us to work the whole thing in the best possible way. Then you will offer some support to your colleague in the end. For example, if he's having some family issue or some problems with like some problems with work or whatever, you will offer him some support, like ask him to go to the occupational health department or the GP to seek help. In the end, do not forget to tell your colleague that he should not drive back home. If it is a station of alcohol colleague or if it is a station of the cocaine colleague, please ask them about do not drive back home because they are dizzy. And for dizziness, you always to warn the patient or the colleague to be safe. How to be safe? By asking someone to accompany them. Okay, in any dizziness or any substance abuse, do not let the patient go back on their home to their home on their own. Okay, do not operate heavy machinery. Do not stay alone at home at least for today, because they're more liable to have a fall if they are not helped by someone. Okay, regarding the concerned patient or the worried patient, it is about your approach like reassurance. Always reassure the patient. If the patient in PLAB 2 is not opening up to you, you have to do three things. Number one, reassure. We are here to help you and support you. Whatever you're sharing with us will put us in a better position to address your concerns and help you in a better way. This is number one. Number two, if the patient still did not open, sympathy and empathy. I'm sure you're having maybe a tough time, but believe me, whatever you're going to share with us will put us in a better position to help you out. Number three, confidentiality. Let me assure you that whatever you're going to share will stay confidential between you and us, the medical team. Okay? So number one, reassurance. Number two, sympathy and empathy, especially if the patient is really having tough time. Number three, confidentiality. Those are the key and the magic to any patient to open up. Okay? Okay. In any ethics station, if you say confidentiality or mental capacity or any term, and the patient asks you confidentiality, what confidentiality? Now you have to stress on your point of view by explaining what is confidentiality. You will see that confidentiality is the center of the trust built up between the patient and the medical team. Unless for it, our patients would never trust us, and they may underreport their symptoms. And I'm sure you agree with me, this will definitely have bad implications on the way we are going to treat and support the patient. Right? Okay. So now we are done with our session for today. It was a quick, I consider this was a quick session, and by the way, some people may consider that it is not useful, but believe me, it will show you the opposite in the next few days. You will see the opposite, because this session is the core to many coming things. What will happen? Today, I will work on the papers because I did not have time to work on them. I will send them to you tomorrow ultimately, before the session. I'm going to ask you to have a quick look at the papers only in 30 minutes or maybe 1 hour. You will just learn how to elaborate the symptoms, how to approach the cases, how to be reactive in the station. Okay. One important thing, please, guys, is that I need you, inshallah, every day. I will provide you with a list of the stations to be discussed before that. If you can read them before coming, I will be thankful. If you cannot, still, it's fine. But my approach is different from what you are going to study. Why? Because I'm going to teach you symptom-wise. I will not teach you the full script and after finishing you will forget it. No, I will link all the scripts together. Okay? This is time-saving and at the same time this is more beneficial and useful to you because this will cut your time short when you are studying and when you are revising. The total plan of my course, Dr. May. By the way, I'm done right now with the session. Wait, let me stop the recording because this is done.